Okay, so today I'll try to show some of my cases. I'll try to quickly point out the nuances of each surgery and moreover try to give you an impression that there are so many things that we can do with one approach. So most of the time we know that pelvic acetabular fractures are severe injuries, and if you could do one approach to address both columns, it saves you the whole pain of having to do a full another approach. So mapping is usually a very good idea, especially for beginners who are trying to get to understand the pelvis. So here you would want to take a pelvis model and map all the fractures. And this actually, if you keep on looking at this fracture pattern and from all corners, it gives you a sense of the direction of the fracture. And many a times there is some unconventional fracture and some unconventional fragment which you can actually lag from across the column and get a good reduction and hold these fragments. So I actually depend a lot on mapping, and to this date I usually like to map my surgeries. So this is, I usually like to describe my cases as if they're anterior approach or if they're posterior approach. So this is one simple example wherein the patient had a sacral dissociation and a sacral fracture on the other side, and it was open book kind of injury. So we actually, this was a good case wherein we actually tried all the three possible screws for the sacrum. So the top screw that we see is a sacral alar screw. The bottom one is a S2 screw, and then we have the conventional iliosacral screw. And we did a conventional Stoppers approach, fixed the anterior part first, brought it into reduction, and then we went ahead with the posterior screws. Now my trick on this one is, when I do this, is I typically check my reduction with one of my fingers going all the way to the SI joint, which gives me a good sense of the reduction I've been able to achieve, and then pass these screws. So this is another similar case, a vertical shear with unstable pelvis, both ramus fracture, and we again did the same very technique, wherein we plated all the way along the pelvis brim. Now, if you see, these two screws are pretty collinear, and I like to use uh, the guide, what you call the shaver guide, which I was describing about, and get to a very perfect point which is totally horizontal, gives me a plane, and I like to drill across from, say, if I'm trying to fix the left vertical shear fracture, I'll start from the right side, because it's difficult for the assistant to exert attraction and maintain the reduction. So I like to go from, if I'm doing a left side, I'll go from the right side, park my bead pin right at the fracture line, have my assistant or myself pulling the fracture down while I'm feeling the reduction. Once I have a reduction, I'll go across with that pin. Now, usually the pin has a tendency to skive off if you are starting right there. So if you have it coming from the other side, you can actually just drive it through without having to care much about what it looks on the C-arm view. So the technique that I follow for the iliac screw is very simple. I like to mark my top of the sacrum, and then I like to mark my line actually, which is the midpoint of the sacrum, and I put an incision right at this point. Then I use one of these tubes, which is basically like a shaver sheath, the outer sheath, and try to get a pure concentric hole, which will actually make me horizontal with the bed. Once I have this, I'll pass my bead pin, which is usually a long bead pin that I use, and I'll drill across. So so at this time, if I have my sheath well placed and sunk in the bone, so passing the bead pin is not a problem. I like to do all my passing of the bead pin, especially taking an inlet view so as to make sure that I'm not breaching the anterior cortex, and then you can put in a screw and get in a good reduction. So this is another case. So there are times actually when some of these fractures would come to you, and they would have other injuries as well. So this was a patient who had a bladder rupture, and extravasation of urine in the abdomen. And on top of that, he had a typical open book with a vertical shear, the SI disruption. Now, these are the cases where the general or the neurosurgeon would want to go in right in and address the problem for the fear of urosepsis. Now, the the neurosurgeon actually did a urethral repair. He repaired the bladder. Just because we didn't have a conventional standard pelvic plate, we used a DCP to put in this anterior plate and put in the iliosacral screws for a good reduction and to maintain the fracture. This is again another case. So a patient knocking in comes to you in the night and has a bladder injury with extravasation, unstable situation wherein the surgeons are wanting to explore the abdomen. So this is one typical situation wherein I have learned from my mistakes is to work in sync with the surgeons. Now, if they are going in anterior or they have opened a midline approach, so it's difficult for you to do a later surgery, and you would always want to fix some of these fractures. Moreover, the neurosurgeons would want that you should have a stable a pelvis when they are doing their repairs, so that they can park some of their sutures, especially at the bulbourethral junction to the bone. So in this situation, again, we were able to get a pelvic plate. We did a sopas, like it wasn't a standard sopas. They had opened midline. They did the urethral repair and the bladder repair. And we put in this plate. We fixed the neck fracture at the same sitting and then came back for the femur fracture later. So this patient did excellent, had a union of the neck femur fracture as well. So another patient, similar patient, urethral injury, bladder injury, we fixed them on day one along with the surgeons. So this is a little unconventional case wherein rather than having a sacral dissociation, he had a fracture right at the margin, and it was an unstable situation, so we decided to do a Stopa's approach, fix the anterior column, and then come back and put these two screws. The idea for these two screws came from the fact that this is the trajectory of the iliac screws when you operate the spine. When you want to dock the spine to the pelvis, this is the trajectory that you want to go to, and usually you can put in a 90 mm or a 85 mm screw, which gives a pretty good hold in this situation. So this is another patient who came with a pretty bad injury, had a bladder rupture, and this is what his 3D CT scans looked like. So he had what we see over the pelvis, and he had a bilateral sacroiliac dissociation on both sides. Now the surgeon and the neurosurgeons were wanting to explore the abdomen because the patient was unstable, and they found that he also had a bladder injury. So the point was to do this surgery along with them, because if you don't, then it's difficult to come back and do a significant work with this one. I feel a bit jittery when you have all those drains coming out and the patient has already had an incision over the abdomen. So for the fear of infection, I would want not to do that and rather work in sync with them so as to be able to fix this fracture. So we were unable to get the regular pelvis set that we typically use. Those days we didn't have a synthes set in Ranchi. So we had to work with a local set which didn't have the perfect sizing. The general surgeon actually repaired the bladder. He did a urethral repair, and then we fixed the fracture. So we went, and the idea here was actually to get a reduction of the iliac crest, and then we went in and rotated this fragment, uh, the superior dome of the acetabulum and this big fragment. So we flipped it inside and we got a reduction. Once we got a reduction, we put in a 6.5 screw percutaneously to hold this reduction. With this reduction of the dome, we then used the Stopa's window to put in a plate and then another plate to bridge this area so as to give him a pelvis. Now we see that the SI joint is still open. We didn't care much about it on day one. And then we came back after 2 days, wherein we did the femur fracture nailing and put in a iliosacral screw. So this patient did really well. He has a perfect normal range of motion, and we were hoping that for avian, but he did pretty well. Uh, Now these are the ones which we did through the posterior approach. This is a posterior column and wall fragment. So I'll try to explain my philosophy when I address these kind of fractures. So, so for this patient, what we did was we put in a shank spin in this fragment, the ischial tuberosity, and tried to rotate this back. Once we had a rotation, then we put in a clamp to reduce this, and put in two plates actually uh, to get a good reduction. But as we see that we have a pretty normal reduction where all the fragments are well reduced, and this patient went on to get a good outcome. Now, if you look at this, we decided to put in two plates. One was to hold the column, and second one was to hold the posterior wall fragment. But typically in these unstable situations, I like to have two modes of fixation. So either it can be a 6.5 screw, which is going all the way from the posterior column to the anterior column, and a plate, or I like to put in two plates. So based on the fracture pattern, I decide on that. But okay, so this is another patient, a similar kind of fracture, wherein we reduce this fragment in the ER, and then once we had a reduction, we posted him for surgery the next day. So usually I like to put in my clamps through the sciatic foramen and go all the way to the anterior column. It's almost like I get to feel the anterior column with my finger, and I typically park the spike on that anterior column and try to approximate. Now these are the two essence, as Magusa was saying, that you would want to have a perfect dome and a relative reduction of the anterior column in relation to the posterior dome. The posterior wall fragments and the column, you would still have a chance, but if you get this right, all the fragments will fall in place. If this fragment is not reduced, you'll find it difficult actually getting a good reduction of the posterior column and wall. So once we put this, we had a good reduction. So we passed in a guide wire. Now this is a screw uh, which I learned actually from Dr. Archdeacon, and which he supposedly calls his magic screw. And I realized that it has all the potential to be called so, because it gives you a very stable fixation of the anterior column as well. If you're able to do this perfectly, uh, once you put in this screw, your pelvis will feel rock solid. With just one 6.5 screw, you'll feel that you've had your reduction. You can open the clamps that you have put in, and you can just address the posterior column and wall, and get away. So we did that, and then we completed the fixation with another plate to get a good congruous reduction, good reduction uh, at the anterior column. It looks pretty concentric, and it's very well reduced. Another case wherein we did the same thing. He had come in with a fracture dislocation. We reduced the patient in the ER, and this is what it looked like after the reduction. We again used a 6.5 screw to go all the way into the anterior column, and then augmented our construct with one posterior plate, giving us a good stable construct, and he also had a very good reduction. Now my landmark for this posterior to anterior column screw is very simple. Now typically if you draw a line through the superior portion of the greater sciatic notch, uh, at 2.2 centimeters, if you bisect it, the inferior quadrant of this bisection is your starting point, and this is for males. In females, just because they have a broader pelvis, if you select a point which is approximately 3 centimeters, you'll get that perfect spot. Most of the time, you have to actually check your point radiologically also in various planes, but if you look at the pelvis and if you decorticate this area, you'll realize that it's a kind of a funnel that actually leads you to the anterior column. So if you get that funnel right, it has almost a 1 centimeter square area wherein you can actually position your screws and just go in and get a good grab of the anterior column. So it's like a funnel. It'll direct you to the anterior column, and you can get a pretty stable reduction. Once this screw goes in, you'll find that your pelvis would start feeling very stable. You can open the clamps and just wait to get a good reduction with the posterior plates and screws. This is another, like a different case altogether. It's an uncommon posterior wall fracture. So, so this patient came to us with a hip dislocation. We reduced the fragment back, got a CT, and we realized that there was a small floating fragment here, and the head was not concentrically reduced. Now, the fragment per se looked small, so it wasn't a big fragment, but what we realized was there were like loose pieces of bone, and which was pretty big. The point was that the fragments didn't look solid, so we, though it had a bone to it, but it looked somewhat feathery. So there was no choice but to go in and fish out this fragment out. So we went in. When we went in, we realized that this was the sleeve avulsion of the labrum, which was dragged into the joint with our reduction maneuver, and it was persisting there. It had a full attachment of the labrum. We pulled this out uh, and repaired this back to the margin of the acetabulum with 4 drill holes, and we were able to put this small bone actually in that, and this supported our reduction. The hip was very stable right on the table. So we augmented that small bone piece with a small plate, like a buttress plate, and then put in another rim plate. This patient was a young kid, and he did very well. Post We had a chance to see him actually after 2 years, and he's still doing great. So this is another bad case actually, and these are some of those cases wherein I'll try to show how we were able to get some good reduction in these patients. So looking at the fracture, he had a displaced anterior column fracture, and there was a big posterior column fracture and a posterior wall fracture. The question was, which approach would you want to go? Given the posterior wall and column displaced fragment, and that being comminuted, we chose that we'd start with the posterior approach and try to see if we can get a good reduction in this situation. There was actually, if you look at this CT cuts, you'll see that there was some impacted fragments and some bone loss also, more on the medial side in this case. So we actually did the same thing. We tried to reduce the anterior column with the posterior column and put in a screw to hold it. And then we used two another plates for the comminuted posterior column and the posterior wall. So there was some diastasis of the pubis which was less than 3 centimeters. So we accepted that. We put in screws in the sacroiliac joint, both sides, because both of them were disrupted. One side had a sacral fracture, the other side was a pure sacroiliac dissociation. So we did that. And then we waited, actually. We got a CT scan to make sure that all our screws were in. So this is the immediate post-op CT scan. And you see we had a pretty concentric reduction of the anterior column as well as a good superior weight bearing dome. So we decided that we'd skip the anterior approach in this patient, and 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 this is the same patient actually. He had significant post-op pain. I was little concerned for the fear of developing a vascular necrosis. This is 3 years post-op video wherein the patient is able to squat and sit down, and his X-ray still looks good. No sign of a vascular necrosis or any arthritis as yet. This is another patient, and this is like every person has one bad case which they remember for their lifetime. This was that case for me. So this is a 44-year-old female who had a free fall on a lift from the 9th floor. Now, she came to us in a state of shock. The immediate hemoglobin was 3.5. She had a displaced fracture of the, as well as disruption of the pubis. It's very rare to get a pubis diastasis as well as a ramus fracture, but this was a bad situation. And we could figure out that one of the hemipelvis was rotated outwards and it was proximally migrated. So with a CT scan, the surgeons found that she had a gut injury. She had a bladder rupture. It was all torn into pieces. She had a urethral injury, and resuscitation was not helping her. They were pumping fluids and blood, but her blood pressure was not improving. So with the help of a brave anesthetist, the surgeons took her uh, for surgery and decided to open it. My idea was if it would bleed, we'd do some pelvic packing and put in an external fixator, give some compression so that we can come back. So they did a midline approach. They did a bladder repair. They repaired the liver laceration, and uh, and I typically put in an external fixator on this one. Till that time, we didn't have a pelvis CT on her, and this is what it looked like. So see, she had a type 2 sacral shear fracture, and part of her spine had actually like invaginated into the pelvis, and it was a high velocity injury, a fall from the ninth floor. So this was expected, and we were able to neatly bring down the anterior open column with the help of an external fixator. As you see that we were able to get an anterior good like a good compression and a reduction. We were hoping that her hemodynamic parameters would improve, but in 2 days she required multiple transfusions, and the drain which the surgeons had put in was putting out 800 to 1000 ml of blood every day. So she was hemodynamically stable, had hemoglobin of 6.9. She already had 14 transfusions in 3 days. She was even worse look-wise. She was worse than what she looked on the first day. And drain output from the pelvis was not improving. The spine was dissociated from the pelvis, and we were hoping to fix that. Now the issue was, how would we be able to do that with such a comminuted sacral fracture? How would you actually fix that? So we actually had a discussion with the family. The family had almost lost hope and said, let's take a chance. Let's try to fix this pelvis and see if her hemodynamic parameters improve or she gets stable. So we took her for surgery. We changed her the external fixator to a pelvic clamp so that she might not like dislodge all those blood clots that she had formed inside, and maintain that anterior closure that we had initially. And then we turned her, and this is what she did, what we did. So after fixing the iliac and the lumbar screws, we started distracting the rod. We started distracting here to get the desired reduction of the sacrum, and then we use a side to side clamp on these two rods to get a compression of of the ilium together. So we used a cobalt chrome rod on this one. So the pelvis was stable that very moment. She was very stable. We could move her pelvis, and she wasn't moving an inch. Though we actually went back and put in the anterior fixator that we had just to make it more stable, but I'm sure that wasn't required with the fixation. So this is the reduction of the sacrum that you see actually on a sagittal CT scan, but it's pretty much in line. All that the migration that we had initially had corrected, and the drain output started improving right away. She was hemodynamically stable and out of that NORAD and pressor support that she had initially, and she was extubated after 3 days. 6 days later, we took her for surgery. We did a tibial nailing, ankle fracture fixation, and also repaired her posterior dura, which was like torn miserably. So we had to put in a dural patch, and we did that dural repair after a sacral laminectomy on this patient. And this is the final X-ray after 6 months. But 6 months later, she comes back to us. She was walking. The only deficit that she had was a left side foot drop, and she had mild stress incontinence. Uh, so these are the cases where you always thank God, because we just got lucky with her. We could have lost her any day with so many things going on with her. But she was a fighter, and after spending almost 26 days in the hospital, she finally went back home. So my take home points today is that anatomy is the key. You would want to appreciate the anatomy better to plan your screw directions, and get a like so that you can play around in the pelvis. So just admire the pelvis model and you'll know that it's so better to understand and to know the pelvis well. Planning is the key. I usually would spend like an hour looking at the fracture pattern with various 3D fracture patterns, the coronal sagittal views, just to get a better understanding of the fractures. And once you get that, start to develop a correlation of the fracture patterns, and you can actually start taking them in your stride. So my principle is one approach is better than trying to do two. I have done two approaches. I'm not putting up those cases, but I've done two approaches on various situations. But those were difficult and different cases. It's important to understand the limitations. It's important to have a team approach when these patients come in as a polytrauma patients coming in shock, coming in with bladder injuries. So it's important to ask for help when you need them. Just get in touch with your urologist or a general surgeon friend, and they'll be right by you and help you get a good outcome from these bad fractures.